Welcome to our annual AOA conference, Visiting Professor Conference. I just have a few slides with some of the news from AOA from the past year. These are members that were elected in the spring of 2025. These are junior AOA members elected at year 5. And I'm not going to read the names, you can just see them. One of the slides has lots of names on it. These are senior members elected in the spring of 2025 that are graduating soon, hooded today. These are senior members elected in fall 2024, long list. I'll give you a few seconds to look that over. And then these are junior members that were elected last spring that are the current student officers. And then some residents that were elected spring 2025. One of them's in the audience, I think. Dr. Lucchini had to be, he's away. Okay, and then just Monday night, I got this email. The important part of it is right here. On behalf of Alpha Omega Alpha, I'm very pleased to inform you that the University of Missouri Kansas City submission titled UMKC Cataractathon has been awarded an AOA Medical Student Service Leadership Grant. That's $9,000. That's a really good grant. I will send out to you notices of the availability of these grants when they come up to me. And you can, and one other thing about that, Nitin Nadella, one of our students, year 5, was awarded a Carolyn Kukine Award, Student Research Fellowship from AOA last year. And that work is in progress right now. Okay, and now, I want to introduce our speaker. We're very fortunate to have her with us this few days. Dr. Teresa Nguyen attended medical school at Jefferson in Philadelphia, Pennsylvania, and then completed her residency training in emergency medicine at Christiana Care Hospital in Newark. She's an associate professor of emergency medicine and director of the Center for Community and Global Health at Loyola University in Maywood, Illinois. She co-founded the Loyola Street Medicine Program in January 2020, which is dedicated to providing medical care and social outreach to individuals experiencing homelessness. For her leadership of this program, she was named the Loyola Medicine Spirit of Dr. Martin Luther King Award in 2022. Dr. Nguyen hopes to empower students and providers to advocate for their patients through the social determinants of health lens. Please join me in welcoming our speaker for 2025, Dr. Teresa Nguyen.
Thank you, Dr. Foxworth. You guys, can you hear me okay? All right,
Okay.
perfect.
You're ready to go, I guess.
Yes, ready to go. And we're going to pray that Pull Everywhere works. But hello, everybody. Thank you so much for hosting me today. So as Dr. Foxworth mentioned, I'm coming to you from Loyola, which is actually situated in Maywood, a western suburb of Chicago, but I still work very closely with a lot of the street medicine programs within the Chicagoland area. And I titled my talk, Care Without Borders. So I actually have a background in global health. That's actually how I started out my career. I thought I was going to work internationally. I was going to help develop the specialty of emergency medicine in other countries. And so in the early start of my career, I actually had spent some time in Peru, Vietnam. I actually went down to Haiti post-earthquake and actually taught at the Partners in Health Hospital Mirabelais when they created an EM residency program. And throughout those adventures, I was always really blown away by the healthcare disparities that exist, right? And recognizing too that when I came back to my own ED, right, that those disparities still existed in my very own backyard. And those underserved populations were still coming through the doors of the ED. And so emergency medicine is very much a specialty where we take care of anybody and everybody, any time of day. And so this is really a lot of what sparked my interest in working with underserved populations under that umbrella of community and global health. And so I titled this Care Without Borders because I think it's really important for us, especially as healthcare providers, to really recognize that we can transcend boundaries and that we can care for patients not only within the confines of our clinic, our hospital, emergency department, but even take it to the streets, take it without boundaries, and really be able to provide meaningful care for a patient population that's very much often stigmatized and underserved. So to begin with, I'd like to make this engaging. I'd like to make it a little bit interactive. So if you guys are able to join me on Pull Everywhere, you can either pull up text on your cell phone, or for those of you who might be live streaming, if you can join me on, you can pull up the website as well. So pullev.com/TWIN700. Hopefully it's working, and then we'll see if the first question pops up. Is it working for you guys?
The first question I have is, what are some new words, ideas, or images that you associate with?
Okay, let me see.
Now it's showing that.
Okay, all right, let's start again. How about here? Okay, great. So getting some responses here. Okay, some mixed answers here. And as a follow-up to this question, is this popping up for you guys? What are some words, ideas, or images that you associate with homelessness? Hopefully I don't have to keep activating this for... Okay, looks like it's popping up. Okay, great. So a lot of different words popping up here. I see drugs, poverty, poor being a big one, mental, assuming mental health, tied in with that. Would you guys say that most of these words have a positive or a negative connotation associated with it? Negative. So there's clearly some opportunities here in terms of how we view homelessness and how we can change the narrative, right? And I'm hoping we can at least, just even in the discussion we have today, change some of that perception on how we view individuals experiencing homelessness and how we can better care for them. And many of those images that you might see often have those negative connotations, right? It might be the encampments that you often see with the tents, or maybe it's that classic stereotypical shopping cart that might be missing a wheel with the luggage in it, or disheveled appearances, or perhaps somebody that's panhandling. And so these are many of the common images, words that we associate with homelessness. But my challenge is, why can't it be this? These are real patients, real clients of several of our community partners. Individuals who had been homeless that now have access to care, access to housing, access to vital resources that they need to stay alive. But how do we get from here to here, right? And as clinicians and as students, right, we often learn about clinical spectrum of diseases, whether it's mild, moderate to severe. And I like to think of homelessness very much in that similar spectrum, right, is understanding and recognizing homelessness. We think about the clinical spectrum, we think about epidemiology of disease. And when you talk about homelessness, you can discuss this range anywhere from housing instability. Perhaps it's the single mom raising 2 kids who's trying to work full time but struggling to pay for rent and keep up with utilities. Perhaps it's an immigrant family who came here and have limited resources, limited access to care, and they're living doubled up, right? There's many pictures and images and situations that bring about housing instability as well as homelessness, to the most severe case, which is what we call our unsheltered homeless. So these are individuals who are homeless, meaning that they lack a stable residence, a place to sleep at night, but then are also staying in places that are really uninhabitable and that really not meant and stable for living. And so when we look also at the epidemiology of homelessness, it's an epidemic that's growing. These numbers keep increasing year to year. So as of last year, over 700,000 individuals experiencing homelessness in the US over the last year. It's a pretty staggering number. And the question is, how did we even get here in the first place? Why are we even dealing with this problem? And I think to understand that, there's many structural and systemic causes of what drives homelessness. But also for us, I think as healthcare providers, it's important to recognize too that many of these issues actually stem from childhood. So there have been a lot of studies that have actually shown that nearly 80% of individuals experiencing homelessness have suffered some form of childhood adverse event, whether it be sexual abuse, domestic abuse, or even violence within the household. And I think many of us are familiar with the concept of adverse childhood events and those negative outcomes on health in the long term and short term. For individuals experiencing homelessness, over half of them have had 4 or more ACEs in their lifetime, right? I mean, that's pretty staggering. And so they're already, in a sense, already set up for failure, right? Our system has not made it easy for these individuals. And then on top of that, society as a whole continues to marginalize individuals experiencing homelessness. They continue to increase barriers to care. And then there's a lot of myths that continue to be perpetuated, right? And so there's one myth in particular that I wanted to address, and that it's that people choose to be homeless. Now, if you think back to what I just showed you in the previous slide, right? If you have somebody that was born into a household where it was limited income, maybe a mom struggling to provide ends meet for her family, maybe a dad who was never in the picture, or maybe that childhood violence that came into play, right? They're not gonna have an easy life, right? So they're already kind of behind the 8 ball. And so even our system doesn't have adequate resources to care for them and to help guide them along the way. Now, there are some systemic laws in place, especially for kids. I don't know if you guys are familiar with the McKinney-Ventnor Act, but it does provide provisions for homeless children in terms of being able to have equal access to school and education. But even then, that's not enough, right? And then this further perpetuates the myth that people choose to be homeless. And I think a big part of this is to understanding that there are many different reasons why someone might end up homeless. And I think the next time you encounter somebody experiencing homelessness is to really learn their story and what contributed to why they're even homeless in the first place. Another myth that I often hear, especially from somebody who works in the emergency department, and we often see individuals experiencing homelessness, is why don't we just discharge them to a shelter? That would be the easiest way to go, right? But there's a lot of barriers to actually entering into the shelter system. So shelters are actually very limited. There's oftentimes not enough shelter beds for the amount of individuals experiencing homelessness living on the streets. There's also a lot of restrictions that are in certain shelters. So there's certain times, days and times where you can go and enter a shelter. And I think that's important to keep in mind because I've actually had this happen when I've been taking care of a patient in my own ED where somebody is already established at a shelter. They've been waiting hours to be seen. There's still a workup that needs to be done. And they're chomping at the bit to go, right? And they're going to leave AMA either way because they have to get back to that shelter. Because if they don't get back on time, they're going to lose that spot. And so rather than judging them and rather than saying this patient is non-compliant, this patient is leaving against medical advice, I've really tried to take that extra step to call the shelter to see what the rules are, to say, hey, I still need this patient here for workup. He'll probably get discharged, but can he still come at 8 o'clock or 9 o'clock tonight? And sometimes I'll actually have pretty good success with being able to have the shelter hold a bed. But I think it's important to recognize, too, why shelters not necessarily are the best answer. A lot of times patients experiencing homelessness are also homeless with their families, with partners. Maybe they have pets. There's restrictions, too, in a lot of shelters on those. And very much, oftentimes there's really not a lot of privacy. These are actually some real-life quotes that I've learned from some of my own patients, from some of their shelter experiences. First shelter I was in farmed us out as a slave labor during the day, and if we complained, they kicked you out. The shelter was eventually shut down by the FBI. Living in a shelter was one of the worst experiences of my life. They take away your freedom and your dignity, and I wouldn't wish that on my worst enemy. And related to this specific patient encounter, once they got to the shelter, they were forced to put away all of their belongings in a locker, which was, eventually stolen, and so they couldn't even feel safe with having their singular belongings in that one particular place. So imagine if you had everything you own that was important to you, and that was taken away. And then on top of that, she had also just started her menses when she came to the shelter, and when she tried to ask for feminine hygiene products, the staff workers there made a big scene of it and really only didn't give her what she needed, and she felt very ashamed and embarrassed, right? And so, again, this is what our society as a whole has done really to make the challenges even more challenging for this population. And then finally, there was another shelter in the area that was a faith-based shelter. And when you go there, you would actually have to sign a contract to participate in Bible study, to participate in some of the church events. And based on the specific contract that you signed, you were allotted either the nicer scrubs or the hot showers or certain amenities that we take advantage of and get to appreciate every day. And at the same time, they were also allowing drugs to be circulated there. So some very key perspectives that I think are important to know and recognize too, especially when we think about, why don't we just discharge to a shelter? So back to Pool Everywhere. Which state has the largest population of homeless people? Here in California. So a little fun fact, I love maps, so I always try to incorporate at least one map into all of my lectures. So this is our map for today. Okay, we got a lot of votes for California. And you would be correct. So this is actually based on the point-in-time count that's done every year. So for those of you who are not familiar with the PIC count, or the point-in-time count, it is actually a HUD-mandated count that happens in every major U.S. city in the U.S. on a designate in January. And what that does is it gives you a snapshot of homelessness in that particular city. And those demographics and those statistics are then used to drive innovations, strategies, as well as funding that goes towards advocating for individuals experiencing homelessness. So then within each state and city is something called a continuum of care that actually gets the funding from HUD to then allocate to specific resources that go towards housing. So based on last year's point-in-time count, those of you who guessed California are correct in that has the largest percentage of individuals experiencing homelessness. Some of the other states that you might be interested as well, so Missouri, Kansas, and Illinois there, just for comparison purposes, just to get a sense of epidemiology.
How do they do that? How do they do it?
The point-in-time count?
The number of folks who...
Yeah, so it's clearly not an exact count, but actually what happens is all of those organizations that are involved within a continuum of care, as well as volunteers that are trained to do the point-in-time count, will actually go around and canvassing shelters, trains, airports, and that's how they collect statistics. And there's actually a pretty detailed survey that they get. So actually, if you're interested, you can go online and get information about Missouri's Kansas City point-in-time count. And so that data is all publicly accessible. So actually, if you want to take a deeper dive, perfect segue. So if we look at Chicago versus Kansas City, right? So O'Hare is up there, top left. And there's actually a train station line that actually runs through some of the downtown Chicago. And this is where a good majority of individuals experiencing homelessness are actually concentrated. And based on the point-in-time count, this is some of the demographics that we've discovered based on our city. So predominantly male, predominantly African-American, with the age distributions ranging from 25 to 40 or 41 to 60. And in addition to that, this is important because when I talked about this data informing practices, so we had actually found that nearly half of our unsheltered population is using the CTA as their primary means of shelter. And this is predominantly as a result of COVID. So because of COVID, a majority of the shelters shut down, the rotating pads, shelter models actually changed, and so everybody ended up on the train. And because of this blue line, the Chicago Transit Authority, which is the public transportation, the train station, or the train line, it actually runs from O'Hare to Forest Park. And so this was actually a big driving force behind why we actually now do our outreach at the CTA train station. And then another important fact is when we talked about that spectrum of homelessness, is that many patients or many Chicagoans experiencing homelessness actually stay with others at some point. So there's that doubled up phenomenon, which we sometimes don't think about. And while I like to think of Chicago as a sanctuary city and a fairly progressive city, there are still some things that need to be done, right? So this was actually, I was super proud to be home of the DNC last year, and this is the news that I'm getting, right? So spending almost $1 million on building a fence to lock out homeless people. And there was also encampment sweeps that were happening prior to the DNC as well. And we'll talk a little bit about the impact of encampment sweeps as well. And so this is actually the Forest Park train station where we do our outreach. This was what I woke up to on Labor Day morning, is that 4 individuals sleeping on the train had been shot and brutally murdered by virtue of the fact that they were homeless. Switching gears to local hometown here, so Kansas City, obviously with a Kansas and Missouri divide, so this is based on the Missouri time count. So also predominantly African American, also predominantly male. The age distribution actually, interestingly, is much younger, and as I was doing a little bit more research, it sounds like there's a lot more children, school-age children, experiencing homelessness in this Kansas City, Missouri area, which I'm actually not entirely sure why that is. And also, something of note is that when you talk about your chronically unsheltered homeless, there has been a significant rise in the last few years, and Kansas City actually has the highest rate of chronically unsheltered people in any major city in the US. And as I was looking further into why that might be, I actually looked at some of the housing composition in the last decade. And it looks like Missouri's approach to tackling homelessness is actually trying to create more permanent supportive housing, which I do agree with. I think that that's important. And while that has been on the steady rise, unfortunately, the shelters and emergency transitional shelters has declined. And so that's actually forced more people out to the streets. So I think this is relevant too. And then on top of that, right, we have state and local ordinances that also criminalize homelessness. So any guess as to how many US states have some form of law criminalizing homelessness? Did it pop up or no? Okay, sorry. All right. The correct answer is 48. 48 states have some form of law criminalizing homelessness. So I'll give kudos to Missouri. So as of now, it's Wyoming and Oregon, where it's still technically legal to be homeless. Now, there's a difference between state and local ordinances. Missouri was actually the 3rd state to go. So back in 23, Newsom signed into law that you couldn't sleep on state-owned public places. That's a Class C misdemeanor. And so for those of you who also have been following what's been going on in the Supreme Court, last year there was that monumental Johnson versus Grants Pass case, which Grants Pass is an area in Oregon where there's actually a fair amount of homeless encampments. And so Johnson is an individual who was homeless, sleeping in Grants Pass. And there was this big case that went to the Supreme Court about whether or not states and local jurisdictions could have the authority to criminalize homelessness. And unfortunately, the Supreme Court actually voted in favor of Grants Pass. So now they actually do leave it up to the states as well as local ordinances to provide legislation surrounding homelessness. And if you think about it, right, housing is a human right. Housing is not a crime. We should be helping these individuals, not putting them in jail. And many of these laws that are in place do not make it any easier, right? Incarceration just makes things even harder for these individuals. And these are laws prohibiting very basic activities, right? Like sleeping. I think there's some laws about sleeping in a park or even eating in your car, which is most of us at some point in our lives, right? We all lead these busy life schedules. And so I think we'd all be guilty of this at some point. And then on top of that, so I don't know if you guys heard, but earlier this week, Governor of California decided he's going to crack down on homelessness by encampment sweeps. And this is probably one of the worst ways I can imagine cracking down on homelessness. You know, I view encampment sweeps as no different than unlawful eviction from your apartment, right? This is a place where people are living. They have their valuables there. Most have their IDs. Most have their medications there and things that they need to live. And on top of that, many of them that have established themselves in these specific encampments are also oftentimes connected with organizations that know where to find them, that know how to help them, that check in on them regularly. As soon as you do this encampment sweep, you take away their belongings, you take away vital medications. Many of them might have Narcan, right? That's, we all know is life-saving. And then their IDs get lost, and then they have to start this process all over again. You know, it would be one thing if they were doing these encampment sweeps and perhaps setting them up with housing and perhaps setting them up with social services, but that's unfortunately not always the case. And then you think about the costs that the cities are putting into these encampment sweeps as well. And so these are all systemic barriers and issues that have already been put into place. And then now we've got to think about the medical side of things, right, as medical providers. And so I will leave this question up just, you know, for pondering as we talk about some of the health disparities, all right? What is the role of the medical provider in caring for individuals experiencing homelessness? And I'll talk about some of those health disparities and some of those health implications if you are homeless. And this is in addition, again, already to the limited resources and the systemic barriers that have already been put in place. So homelessness creates new health problems and exacerbates existing ones. Think about if you have diabetes. Where do you store your insulin? How do you check your blood sugar every day? How do you comply with a healthy diet if you don't actually know where your next meal is going to come from? If you don't know whether that meal is going to have a lot of carbs, a lot of starches, maybe high in sugar, maybe whatever is handed to you on the streets. What if you have hypertension on top of that? And, you know, typically you might get prescribed a lifestyle modification, right? Eat healthy, exercise, don't smoke, all the things which make it a lot harder when you're on the streets. And so as a result of this, there's a very unfortunate and significant difference in life expectancy between the chronically homeless versus the US general population. This is staggering. We're talking the difference of 47 years versus 79 rather. And it shouldn't be surprising when you think about what individuals experiencing homelessness have to contend with, right? We talked about the life disparities, the chronic diseases, how hard is it from your day to day? And then let's say you're riding the train and you might get assaulted or robbed on the train. They're more prone to injuries. Thinking about where your next meal is going to come from, thinking about how you're going to get day to day, that leads to mental health issues. That can sometimes also lead to substance use issues. And maybe you fall and get hurt. Or maybe you're somebody like the patient I just saw a few months ago in the dead of Chicago winter where they didn't have anywhere to sleep and they lost all 10 toes to frostbite, and now they're disabled. And so this all contributes to those increasing disparities and so many potential complications. And as an EM provider, you know, I always think about where do they end up? Where do they turn to for care, right? They don't have access to regular primary or preventive care. So they then end up in the ED for care, and at a staggering amount compared to individuals who aren't homeless, right? And so this was actually based on a 5-year national survey done over the course of 2013 to 2018. And then when you look at just even a cost breakdown, right? So an ambulance, these are rough costs, but you know, when you think about an ambulance cost, an ED visit, hospital admission. For those of you who've been to Chicago or know about the Miracle Mile, it's Michigan Avenue. There's lots of ritzy hotels on there, so an average night stay is about $600. And if you kind of add it all up, you could probably put somebody up in a nice hotel for a little over a week. For those of you who are Malcolm Gladwell fans, he actually wrote a very interesting op-ed in the New Yorker back in 2006. I don't know if you guys have read it, but it's called $1 Million Murray, M-U-R-R-A-Y. And so Murray was homeless. He lived in Reno, Nevada, And he also struggled with alcohol use disorder. He was well known to the ED there. He was a frequent flyer. He would also oftentimes get arrested for various reasons, and so he would actually get brought in by police. He'd go to the ED, they'd let him sober up, and then he would get discharged back to jail. And at some point, he would get booked, he would spend his time, and then he'd end up back on the streets and drinking again. So over time, over the course of 1 year, they discovered that in terms of the total incarceration costs, ED visits, and all the healthcare expenditures, Murray had accumulated a bill of over $1 million within 1 year. So if you think about resource utilization and healthcare expenditures for this population, that's pretty significant, right? And we already know as a country that we are one of, actually the highest in terms of healthcare costs and expenditures. And so this is actually where street medicine came into play. So back in the early 1990s, there was a family medicine physician named Dr. Jim Withers, who was practicing out of Pittsburgh, PA. He decided to go backpack in hand with a stethoscope, dressed street clothes, and started visiting different encampments. So he started building relationships with these individuals. He started getting to know them on a personal level, learning their stories, and building this street medicine network that has now really grown in the last 2 decades. And it's not just existing here in the US, but it's actually a global program too. So there's actually international programs that exist too. I mean, when you think about countries that are war-torn, that have a lot of displacement, they're also struggling with homelessness as well. And so the Street Medicine Institute is now actually this kind of governing institute that many of the street medicine programs actually rely to for help. There's a lot of standard practices and procedures, as well as policies within the Street Medicine Institute. And I was actually fortunate enough to attend the International Street Medicine Symposium that was hosted by the Street Medicine Institute and Care Beyond the Boulevard this past September, which was here in Kansas City. And so how did Loyola Street Medicine come about? So Dr. Foxworth mentioned that it was January 2020 was when it was officially established, but we had kind of been thinking about this for at least a year or two leading up to the development. And we actually had Dr. Jim Withers come and give a talk at our program and was very inspired by the work he was doing. And so we actually were able to use a lot of the documentation, a lot of the infrastructure that was already set in place by the Street Medicine Institute, as well as several other programs within the Chicagoland area to try to build our program. If you think about what was going on in January 2020, no one could have predicted what we were going to be contending with in the next few months following that. But in some ways, it actually made it a little bit more palatable for us to be able to build this program during those times, right? Because this is when we really needed to be able to offer support and healing to those individuals. So during the pandemic, many of the standard shelter models were closed down, and so they actually were shifted to different hotels. We actually worked with our community partner, Housing Forward, to do a lot of food preparation and deliveries. We also, tried to monopolize on care and services that our institution was already doing. So we actually had a partnership with our pediatric mobile health unit, so you can actually see in the background there. This is a mobile health unit that actually travels around to different schools, different communities. They can provide vaccines. They actually have the ability to do x-rays and to do labs on board. So we were actually able to partner with them and make sure that the kids that were still in these shelters, in these hotels, were not having interruptions in their care due to the pandemic. And we also worked with our community nurse at the time, so doing actually weekly client check-ins at the different hotels. You can imagine how socially isolating it was at that time, right? And then a lot of misinformation too that was being spread, and so we were really making sure that we were checking in on patients, that they were doing well from a mental, emotional, as well as medical standpoint, and providing with the services that they needed. And in the last few years, our outreach has grown. So I mentioned, based on that point in time count, that we wanted to capitalize on the fact that nearly half of our unsheltered homeless were using the CTA as their primary means of shelter. And so about 4.5 years ago, we actually partnered with the Night Ministry, which is another community partner, to set up a street medicine clinic at the Forest Park Blue Line train station at the CTA. So we're actually there every Thursday night from 8 p.m. to midnight. And we're there in a medical capacity, providing medical care for a broad range of diseases. A lot of times we get patients that come by for their regular blood pressure check, maybe they want a blood sugar check. And we're also able to dispense a good majority of medications that they need to. The only medications that we really don't prescribe, just because we don't have a psychiatrist on staff yet, is our psych meds. But we can do a handful of over-the-counter medications. You can imagine there's a lot of chronic musculoskeletal complaints, and so Tylenol, a little bit of Tylenol and Motrin actually goes a long way. We're actually able to refill a lot of medications too for hypertension, diabetes. We have antibiotics in hand too, so a lot of times we'll actually get patients that have acute infections but don't want to go to the hospital for various reasons. And so we're actually able to dispense antibiotics, and then we have them come back and check up on us, check in with us the following week. And so we're able to build some continuity of care. We've been able to build relationships. And it's been a really great way to get to know people's stories. We get to know patients by name. We get to learn about them, their families, their careers, some of the struggles that they have. And over the years, we've also been able to build a lot of services. So street medicine provides the medical care, but we also have community partners on site. And so we also very much rely on our community partners for care. These are some examples, just a few of these are actually, if you can believe it, these are actually minor wounds in comparison to some of the ones that we've seen. And so we do a lot of wound care, a lot of foot care at the clinic. And we also very much rely on our community partners that provide a lot of vital work and support, because we're only there one night a week, but we actually have services that we work in parallel with them throughout the week. So Housing Forward actually is our community organization that helps to provide stable housing as well as interim housing. And in addition to that, they also provide social work as case management, so we work very closely with them. The Night Ministry is an independent street medicine organization that operates 7 days a week. So they actually have both a mobile bus as well as a mobile van that goes around 7 days a week. I think the Night Ministry is like most comparable to Care Beyond the Boulevard in terms of what you guys are familiar with here. And so because we actually have a shared EMR that we use at the CTA with the Night Ministry, they are able to see what we do on Thursday night, and they can follow up, and then we'll provide notes so that we can also see what's happening with the patient. Live for Lolly is a harm reduction organization, and so they do a lot of Narcan distribution, safe needle exchanges, as well as counseling and referrals to inpatient rehab for individuals who are interested. And so we actually do outreach with them on Friday mornings from 11 a.m. to 1 p.m. They actually are in Maywood on Friday mornings. They come out with their purple stigma crusher van, and there's a no questions asked, safe needle exchanges, counseling for individuals experiencing homelessness. And we often talk about actually the trimorbidity of homelessness, chronic homelessness, substance use disorder, and mental health, and that very much contributes to the disparities in life expectancies that we talked about earlier. And then finally, we also have the Shower Up van. So this is actually a national organization that's based out of Tennessee, but there's a Shower Up Chicago van. So there's actually 2, I think now 3 vans that go around the Chicago area, and you can see these are actually very clean shower units. And so these, they're set up with us at the CTA every Thursday. So what works well is usually patients will go shower, especially for patients that have wound care needs. They'll be able to shower, come down to see us. We'll do the dressing changes and then give them the supplies that they need for the week, and it actually ends up working out pretty well. And then in addition to that, about 2 years ago, I actually created this street medicine inpatient consult service. And so any patient that gets admitted to the hospital, regardless of what service they're on, regardless of what chief complaint they're here for, actually gets seen, and we do a full house beds assessment, which I'll talk about in a minute. But we really get to know the patient. We actually serve as an advocate for that patient while they're in the hospital. If you think about most patients' experiences while they're in the hospital, it's very scary, it's very daunting. Most people will usually have family or friends available, right, to ask questions, to show support. And that's kind of what we hope to be as part of this consult service is, we hope to provide resources, but also relationship building. We've had a number of times where I've actually had overlap between patients that I've seen at the CTA and on the inpatient consult service. And what's helpful in those circumstances, right, is since they know us and since they trust us, I can often get them to go to the hospital. And many times, many patients have come to the hospital and have felt judged and have felt stigmatized or felt like their needs weren't being addressed. And so what we really try to do is bridge those gaps between the patient needs as well as what needs to happen from the medical side. And I say this a lot, when I talk about caring for this population, right, is that I think it's really important to understand the concept of competing priorities, right? Somebody might show up in the ED and they might be dying of sepsis, or they might have had an amputation, and that, in my mind, in some ways, is the top priority that needs to be addressed. But to that patient, if you consider their needs and if you consider their situation, their competing priority might be, what am I going to do with my stuff that's still at the shelter? What am I going to do with my daughter who needs to be picked up at 5 today? What am I going to do about this job interview that I should have had today, right? And these are all things that we try to keep in mind while we're trying to create what we call a patient-centered approach or a patient-centered plan for these patients. And we've actually been pretty busy in the last 2 years. So we've seen over 250 patients since this launch. We also have fourth-year medical students as well as residents that rotate on a street medicine elective. So that's incorporated into this consult service as well. And for each of those patients, we actually model our consult note using this house beds clinical tool. So this is something that I would highly recommend all of you can employ with your practice, with or without this consult service. Is any patient that's showing up for any sort of encounter is to get this house beds assessment. So this is a clinical tool that we use to take a history on an unsheltered patient. And each letter of this acronym stands for a different component. And what this does is it gives you that bigger picture of what's going on, right? What are factors contributing to their homelessness? What organizations have they already connected with, if that? And what's helpful is it really gives us a better picture in terms of being able to make recommendations for what might work for these patients. And there's actually a more detailed PDF that breaks down each of these letters that I'm happy to share with you guys if that helps. But this gives us a sense of, okay, I understand why this patient is homeless now. I understand why they have not been successful in partnering with a certain organization, or, I understand why these are competing priorities over the sepsis. And that gives us a much better way to, again, have that patient-centered care that I talked about earlier, and potential outcomes include, not just being able to provide that bridge to care, but providing low barrier access to care. And ultimately, this is the bigger picture of what street medicine can accomplish, right? Is they feel empowered and cared for. They have increased access to care. They feel like they have a choice in the matter. And then the bigger picture, right, of fewer ED visits, fewer repeat hospitalizations. There's actually been a lot of studies that have shown homelessness is actually one of the biggest independent predictors of ED superutilization. Patients experiencing homelessness also are about 10 times more likely to leave AMA compared to the national average of 1.5%. And then on top of that, there's 4 times more likely to have unplanned 30-day readmissions, right? So these are definitely opportunities for improvement that we're hopefully trying to address at the systemic level. And going back to that idea of care without borders, right? So we've been grateful to have a very enthusiastic group of students who have been involved as volunteers, that have been part of a student board. I like to call street medicine our clinical classroom without walls. And so, you can learn about the 32-year life expectancy disparity in a textbook, but when you actually go to the train station and you talk to these individuals and you get to see what they live through and what they contend with on a day-to-day, that really drives home that message and that learning. And so I've been very grateful to all of the students who have been able to participate and volunteer. And so I'd like to close with, now after we've had this discussion, what are some new words, ideas, or images that you associate with homelessness? waiting for Resilient to show up. But overall, more positive than what we started out with. We all agree. And I think that perspective is important, right? That knowledge and that understanding. Whether you go out and do street medicine yourself or whether you take care of patients experiencing homelessness in your day-to-day practice, is just having the greater awareness of and understanding of not only the complexities of homelessness, but how you can better address some of the systemic issues that they are going through. And so just to close with a few summary points. So recognizing and understanding homelessness is key. Treat all your patients with empathy and dignity. Remember that each person has a story and that they've probably sustained a significant degree of trauma, so this is also where your trauma-informed care approach is relevant, and be willing to meet the patient where they are. Finally, because this is the population that I care about for the specific talk, understand the complexities of homelessness and advocate for your patient in small and little ways, because at the end of the day, homeless patients are not the problem. They are the result of the problem. So if you're interested in learning more, please feel free to visit our website, loyalastreetmedicine.com. We also have a podcast series where we have interviews with different content experts and different topics ranging the gamut of harm reduction to pediatrics to infectious diseases. We will be releasing our 5-year anniversary podcast, which will be coming out soon. So very excited about that. And just for more personal look at what homelessness is really like, this is a really well done article by the New York Times. It was actually released last year. It's an interactive article where it actually discusses the lives of 30 different individuals experiencing homelessness, all different ranges. And they ask all of them similar questions about what were the drivers of their homelessness, what was it like being homeless, and what they wish people knew about their story. And so these are all additional resources you can explore. Happy to answer questions as well as take any feedback from the group.
For your inpatient consultation service, who provides those consults? Is it you? Is it a physician? Is it a social worker, a community health worker? Like who?
Yeah, so I oversee the consult service. And typically, I usually will have 1 or 2 medical students on the elective with me. So they'll go see the patient first. We have something called WIND rounds at Loyola. I don't know if that's something that's a universal thing here, but the WIND rounds is basically the multi-professional interdisciplinary rounds that happens every morning by unit. So let's say we have a patient on 7 North. So the student will attend WIND rounds with the social worker, the primary care team, and case manager for all of the patients on 7 North. And they'll talk through disposition, medical management. And so that helps us to actually work cohesively with the team in terms of discharge planning. And then we don't have, so something I'm trying to get is a street medicine designated social worker specifically for our consult service, because as of right now, we get a hospital assigned social worker that's designated for that floor. And sometimes that can change from day to day depending on who's covering. And so that will give us a better continuity of care, not only with the patient, but also connection to resources.
What resources do you have as far as getting people in with more permanent housing or job training or things that kind of get them back on their feet?
Yeah, so a few things that we can do. So circling back. Just X out of this. So at the basic level, we can provide hygiene kits, which include essential items like just even basic toiletries, socks, and things like that. We have actually seasonal hygiene kits that we give. We also have access to clothing as well as supplies. So some patients also might need coats or different shoes, and we're able to provide that like at the very basic level. In terms of the broader resource referrals that we are able to do, so we don't do employment referrals, but if we can refer to some of the community organizations that we are familiar with, they can get connected to resources. Where possible, especially because a lot of these patients don't have cell phones or a primary means of transportation, we will actually call and initiate those referrals for them. So for example, if we want them to follow up with Housing Forward, we will call Housing Forward on their behalf. They'll do the initial intake, they can get the patient's information, and then what we'll try to do is if the patient doesn't have any, if the patient's not getting discharged like to rehab or medical respite or anything like that, we'll actually discharge them directly to Housing Forward's intake center where they can finish that process. And then we can also typically we'll start with, if they're Medicare, Medicaid eligible, there is actually a separate social worker that's hospital designated to do those applications on site too that we can help with. Disability applications, for example, the patient that I mentioned that had frostbite, obviously is now going to qualify for disability, so we started that process and mailed the paperwork for him.
I think one of the elephants in the room whenever discussing street medicine is the finances behind it, and most of, if not all, the care is uncompensated. Where does the money come from? Is it mostly volunteer time from physicians, private organizations, or is there institutional buy-in where they recognize if they dedicate an early amount of money that it's actually cost saving in the long run?
$1 million question, right? So from a staffing standpoint, the bulk of it is volunteer. I have only recently, within the last year and a half, have been able to get a shift moonlighting fee for the medical direction piece. But in terms of the operational costs, a lot of it will come from donations, grants, as well as some institutional funding from both the medical school as well as the hospital. And then I mentioned this briefly in one of our lunch discussions is CMS officially recognized the streets as a billable location for care. So that's something in the works that I've been able to, I've started actually in the last year billing for my consults. I won't bill for services at the CTA mainly because it's a much different dynamic, and I really want to be able to continue to build those relationships without having to get like a social security number, insurance, and things like that from patients. So. Other questions?
Just want to thank you for doing this essential work. I mean, this is at the heart of medicine. It's all about compassion and giving and kindness. So I'm really moved by how effectively you've done this, and I'm moved by the whole motion of this space.
Yeah.
And we'd love to participate in that.
Thank you.
Again, to your point, we're trying to figure out what's possible between emergency medicine, internal medicine, and family medicine. Family medicine has been the standard bearer procedure in the clinic. We just have to have a broader approach to how we do this.
For sure. Yeah. And you mentioned the partnership with Care Beyond the Boulevard, right? Like they know this patient population well. I would lean on them in terms of their expertise and their knowledge in terms of how they've been able to navigate the system. And that's also why we rely on our community partners, because they're doing this day in and day out.
Thank you very much for this.
Yeah, of course.
Passion shows through.